My name is Nick Verma. I'm the Director of Sports Medicine and Shoulder Surgery at Rush University Medical Center. And I'm excited to be here today to talk to you about a new interpositional demineralized bone fiber implant for use in augmenting rotator cuff surgery. And I think that this is a really unique product that hopefully will help us to manage one of the common clinical issues that we see in dealing with rotator cuff pathology. You know, I did a study when I was a fellow, which is some 25 years ago now, looking at failure rates after rotator cuff surgery. At that time, it was about 28%. If you do that same study today, we're probably in a very similar landscape. And so we really need some help in terms of maximizing our ability to achieve bone to tendon healing. So if we think about the burden of rotator cuff pathology in the United States, it's significant. It's about 20% of the general population from a prevalence standpoint, over 500,000 cases of rotator cuff repair being done in the US annually. And of course, that number continues to go up, particularly as we're dealing with an aging population. The clinical problem, as I already mentioned, is the fact that re-tears are not uncommon, and they're becoming more common as the population becomes more active. Tears are larger, and we're operating on older people who wish to maintain their level of activity over longer periods of time. And those numbers are anywhere between 10 to 50%. Some studies going back 15 or 20 years reported failure rates of 90+% in these large to massive tears. So it's really a clinical dilemma. What we know is that this is based on two factors. One is the mechanical side and the other is the biologic side. On the mechanical side, we've made huge progress in the last 20 years. We've optimized our suture anchors, we've optimized our suture material using tapes. We have different constructs and configuration that help us to mechanically grip the tendon. And the reality is we've far exceeded the native tendon to bone interface strength with current mechanical fixation, but yet we still see failures. So what's the reason for that? The reason for that is biology. We're working in a very poor biologic environment. We're working with tendinopathic tissue and poor vascularity. And so it's not the mechanical failure that's occurring, it's the biologic failure that's occurring. If we think back to our medical school days, we have to go back to histology to understand what does the normal rotator cuff interface look like. And it's called the enthesis. And the enthesis is really the organized transition that occurs between tendon to bone. And this is not specific to the rotator cuff. This is at any normal tendon to bone interface. The importance of the enthesis is that it's a very highly organized transition where you go from tendon to uncalcified cartilage to calcified cartilage and finally to bone. And the structural significance of this is that this four-layered structure is really what provides significant mechanical force and strength transmission across the tendon to bone interface, particularly as the tendon is going through different arcs of motion. So remember, the angle of insertion will change depending on whether the arm is in 20 degrees of flexion, 60 degrees of flexion, or 180 degrees of flexion. And the enthesis is what gives us this flexibility to maintain a constant biomechanical distribution of force across the bone tendon interface. The problem is that when we repair a rotator cuff, we don't get an enthesis. What we get is fibrocartilage scar formation or fibrovascular scar formation, and it's a highly unorganized area of collagen, fibrocartilage, scar, and then bone. The problem with that is twofold. Is number one is this scar tissue formation has an inferior biomechanical strength as compared to the enthesis itself, so it's mechanically weaker and it's prone to failure. And in fact, if you look at some of the work that's been done by Ioannidis and others, what you see is that the tendon actually migrates away from the bone following surgery. So even though we get soft tissue coverage over this interface, you can have 8 to 10 millimeters of scar tissue between the bone and the tendon itself. This leads to improper load transmission, risk of failure or re-tears, and incomplete functional recovery or strength recovery with potential of persistent pain for our patients. So how have we tried to deal with this? Well, traditionally the way that we've tried to deal with this is by using patch augmentation or over-the-top augmentation. The challenges here are really twofold. Number one is surgeons, it's pretty complicated. It can be difficult to deliver a patch, to get it into the right orientation, to make sure you cover your repair site, and to get adequate fixation strength across the repair interface. And secondly is if you think about this from a biologic standpoint, we're simply adding more collagen to get more scar, but we're really not intervening on the bone tendon interface, which is the problem here. So the question then becomes is, should we flip the switch? Should we not be looking at putting things on top of the tendon to try to augment collagen thickness and biomechanical performance, but should we really be looking at where healing is actually occurring, which is between the tendon and the bone, right? The vascular supply comes from the tendon, comes from the bone into the tendon, and is that maybe the crucial area where we can improve our failure rates? So this leads to this concept of an interlay or interpositional augmentation, which has some advantages. Number one is biologically, it can help us to improve healing and maybe normalize the interface. Number two is biomechanically at early time frames. If we normalize the interface, we can improve the strength of the fixation. DBM is one of the ways that we can potentially do that. This is demineralized bone matrix, which has a lot of preclinical data that suggests that it does improve enthesis formation in the preclinical setting. So let's look at that a little bit. So what is DBM? DBM is really simply allograft bone with both osteoinductive and osteoconductive properties. It simply has the calcium removed, so it's decalcified allograft bone. What we know is that when we put in this bone graft into a bony setting, it heals by enchondral ossification. And what's interesting is when you stimulate enchondral ossification, particularly at a bone tendon interface, you can actually then reform an enthesis with the normal transitional fibrocartilage, calcified cartilage, and then calcified layers. And that's really powerful when we're dealing with bone tendon surgery. So there have been a number of preclinical data or studies that have looked at this, particularly in the animal model setting, and what they have all shown is that the ability of DBM to reform a normal forward layer transitional zone. So that's a really powerful way to try to recreate the normal tendon bone interface. Now, what Testers has done is a unique ability to actually create demineralized bone fiber. The problem with traditional DBM is that you can't really formulate it into any structural form. You really have either a gel or a putty, really hard to deal with in an arthroscopic setting. What demineralized bone fiber is it's cortical bone that's demineralized prior to cutting. So you take a wedge of cortical bone, you demineralize it, you get this flexible piece of what's essentially a fibrous type material, and then imagine taking a cheese grater and getting long stranded fibers that can then be shaped into multiple different formats. So you can use dowels, you can use trays, you can use sheets. And in this case, you can use pegs that look very much like the anchors that we use with traditional rotator cuff surgery, which makes it very easy for the surgeon to then implant it into the space that we want to use it, to do that arthroscopically, and to get it to fit stably into that location and stay there over the time of our arthroscopic procedure. There is clinical data that suggests that when we compare inlay to onlay, that we see similar reduction in failure rates compared to traditional rotator cuff surgery. So there's data already that shows that with various different products, an inlay format can be helpful. The other real advantage of this is it's an allograft. It's simply human bone that's been decalcified. So the regulation is very straightforward. It's categorized as a minimally manipulated tissue product in the US and other countries, and the instrumentation is very simple. It looks very similar to what you're used to using for traditional rotator cuff surgery. The third thing is because it's human bone, we don't worry about xenografts or other foreign materials that we know can cause inflammatory reactions within the shoulder space specifically, which has been historically a problem. In my mind, what was really game-changing for me as we developed this project was how do we make it such that it doesn't change the way that we do rotator cuff surgery. I don't want to spend an extra 30 minutes trying to deliver an implant or a graft. I don't want to futz around with trying to use sutures to hold it in place, have it float away during my procedure, and to be cumbersome, requiring extra skilled hands to be able to accomplish. So it needs to be simple. I don't want it to change the way that I perform surgery today. And importantly, I don't want to add extra implants, because if I'm doing a 4-anchor repair and then I need 6 additional implants to be able to put in whatever the graft that I'm using, what happens? My cost goes up by 3x, and it's not sustainable, particularly in the outpatient setting. So this was a product that was launched a year ago at this very same meeting. It's now in use in the United States and Australia. The launch has been expanding over the past 6 months or so, and we are collecting follow-up data that hopefully we'll be able to present to you at our next meeting. But we've now done over 250 cases with 500 implants being used in the arthroscopic setting. And importantly, we've seen 0 risk of graft inflammation or graft cystic changes, as you would expect with a bone allograft implant. It comes in various formats. The rotator cuff implant is designed to be used in combination with an anchor. So you prepare your pilot hole, you then tap through the product itself, and then insert an anchor of your choice. It doesn't matter whether it's PEEK or biocomposite. You can even use metal in this setting. And it actually has the added advantage of increasing the pull-out strength of the anchor itself. If you remember the old Interfix devices that we would use for ACL surgery, where you'd put a sheath in and then put a screw down the middle, anytime you're putting down a screw down the middle of an implant and expanding it, it helps to improve pull-out fixation, particularly in poor quality tendon to bone situations. So it's a nice option if you have patients with significant osteopenia. The TAC-O and TAC-T devices are used independently of the anchor. So you place your anchors medially, you place your second row laterally, and then you have the entirety of the greater tuberosity cortex that can then be used with 1 or 2 implants or a T-shaped implant based on how much real estate you need to fill. So this is what it looks like arthroscopically. This is your standard 2-centimeter tear. You can see I've got 2 standard traditional all suture implants on the medial aspect of the tuberosity. I've got a fair amount of exposed greater tuberosity that will allow me to perform my implementation of the graft. I'm going to create a pilot hole. It looks like a traditional awl that you would use for rotator cuff surgery. And then a cutting device goes in that allows us to flush cut a circular indentation, for lack of a better word, into the bone that allows the implant to sit flush at the bone tendon interface. So we simply use a screwing motion to create the indentation for the implant itself. You can see that this further allows for marrow egress and access to the vascular elements of the vascular channels within the bone. The implant is then loaded onto the inserter, and then it's press fit into position, and it really just sits flush over the tuberosity. The nice thing is that once the implant is in place, it's completely stable. So you take the inserter out, the implant's going to sit there, and now you finish your repair as if you've done nothing else. In reality, that entire process takes about 2 minutes from start to finish. So really no change in the way that our rotator cuff surgery is proceeding. We then have our sutures passed, so I like to put my medial anchors in, pass my sutures, prepare the bone, deploy the implant, and then I'm ready to simply just fixate laterally. And you can see that as we do that, the implant is completely covered. We've got nice interposition between the tendon and the bone with complete coverage of the greater tuberosity. We then go ahead and place our lateral row as we would do normally, and this is what it looks like when we're done. So we've got a medial row of anchor, we've got the tuberosity with the DBM implant in place, and then the lateral row of anchors to help augment the enthesis reconstruction. So in conclusion, I think we need to flip the script. I don't think that the collagen is really the answer for improving our pull-out strength. Maybe it can help us in situations where we have extremely tendinopathic or poor quality tendon, but for routine use, I think it makes sense to try to augment as an inlay or an interpositional graft. The graft helps to facilitate tendon to bone healing. There is good data that shows that we can reconstruct the enthesis. It's allograft bone, so it's safe and compatible, very little risk of either cystic formation or inflammatory reactions. And most importantly, as surgeons, it has a very simplified surgical technique that can allow us to implement this in our routine clinical practice. Thanks very much for your attention.